from Madrid, Spain, with a huge experience in musculoskeletal ultrasonography. Jacqueline, I want to thank you to agree to be part of our team. So please, let's see your presentation about musculoskeletal ultrasound guided procedures.
Good afternoon, ladies and gentlemen. It's an honor and great pleasure to share our work with international ultrasonographers. As last speaker, I would like to congratulate Professor Fodor and Naredo for getting us all together to develop these first consensus-based EFSUMB musculoskeletal ultrasound guidelines and recommendations with the idea to improve our knowledge, uniformity, and quality of care. Let me begin with one of the first literature reports back in 1981 that used ultrasound to guide aspiration in a rheumatoid arthritis patient with suspected septic arthritis. They were able to detect the needle in the echo-free area within the distended posterior shoulder capsule for sampling synovial fluid. The development of high-frequency linear probes with different footprint sizes has made it possible to exquisitely visualize all tissues of the musculoskeletal system. Today, ultrasound is the most applicable and feasible imaging modality for routine clinical use in guiding musculoskeletal procedures. Interventional musculoskeletal ultrasound has a vast number of indications and applications depending whether one is a GP, rheumatologist, sports medicine doctor, pain specialist, anesthesiologist, orthopedic surgeon, neurologist, or rehabilitation specialist. Oh, I hope that I haven't left anyone out. The first step of an ultrasound-guided procedure is always to confirm a specific target in the joint or soft tissue. Direct, real-time visualization of the needle is considered to be the superior technique because it confirms the correct position of the needle. We lack studies that directly compare the performance of the indirect and the direct technique. Choose the shortest and safest route of entry. Keep the ultrasound beam perpendicular to the needle and visualize the needle hyperreflective with its bevel usually upward. To become competent, hands-on training and practice is essential. EFSUMB's 2015 General Guidelines for Performing Interventional Ultrasound Procedures are compulsory for the musculoskeletal system. In our task, the guided procedures were classified as 1. Arthrocentesis and therapeutic injections, 2. Musculoskeletal biopsy, and 3. Perineural injections. Please note all the panelists that worked in each section. Next, I will cover the most important aspects and proposed recommendations. Ultrasound-guided arthrocentesis and intra-articular injections are more accurate than anatomical, palpatory, landmark, or fluid aspiration for delivering drugs in superficial, deep, large, and small joints. Steroids and hyaluronic acid are the most frequent injectables used. However, whether ultrasound-guided intra-articular injections improves efficacy warrants further investigation. Since 1952, steroids have been injected into joints to decrease local synovial inflammatory response and pain in patients with inflammatory and degenerative arthritis. Data comparing the efficacy and safety of the different available preparations is limited. Often, steroids injectables are mixed with local anesthetics to reduce discomfort during and after injection. The steroid dose per joint varies depending on the size of the joint, the amount or type of synovial inflammation, as well as the type of steroid. Ultrasound-guided periarticular injections continue to develop and expand, and there are many therapeutic options with varying levels of evidence of their efficacy. We point out that intratenosynovial steroid injections are more accurate, safer, and are more effective than palpatory injections for treating inflammatory tenosynovitis. In addition, very small amounts of tenosynovial fluid can be aspirated for diagnostic purpose. Ultrasound-guided steroid intrabursal injection is effective and safe for treating refractory Achilles enthesitis in patients with spondyloarthropathies. Intratendinous ultrasound-guided injectables, such as dextrose, high-volume cell line, platelet-rich plasma can be used to treat chronic enteropathies. However, evidence is scarce and we don't know whether ultrasound guidance is more effective and or safer than conventional blinded intratendinous injections. Several studies have shown good feasibility for ultrasound-guided pararadicular and facet joint injections in the cervical and lumbar spine, as well as in the superior sacroiliac joint. In general, we must say that there is a need for high-quality randomized controlled studies to assess the indications, efficacy, and safety of ultrasound-guided injectables commonly used in daily practice. Our first three recommendations are based on strong evidence and consensus. Ultrasound guidance should be considered for fluid aspiration, should be considered to improve accuracy of intra-articular injections, and ultrasound guidance should be used in intratenosynovial steroid injection for inflammatory tenosynovitis. The following two recommendations were based on lower evidence and broader consensus, and this is why we worded might be considered. Ultrasound-guided procedures such as high-volume injections in painful Achilles chronic tendinopathy and platelet-rich plasma in plantar fasciitis, patellotendinopathy, and epicondylitis might be considered. Ultrasound-guided therapeutic injections of the cervical lumbar spine and the sacroiliac joints might be considered as an alternative for CT or fluoroscopy guidance. Synovial biopsies are performed for clinical purposes or translational research. Ultrasound is used to guide the biopsy needle or forceps into the diseased synovial tissue, namely in the clinical context of suspected joint infection, to perform histological and bacteriological analysis. This technique for diagnosing infection allows definite diagnosis in 16% and has a direct diagnostic impact in 37% with 100% positive predictive value and a 95% negative predictive value. The success rate in retrieving graded synovial tissue with ultrasound guidance has been shown to be superior to blind needle biopsy technique in both large and small joints. Moreover, the highest percentage of graded tissue has been described in those joints with higher synovitis grayscale scores. Ultrasound-guided synovial biopsies are very well tolerated by the patients. In plane, technique is preferable since ultrasound beam will hit perpendicular to the needle shaft, thus producing optimal visualization. Previous work in the EULAR and OMERACT trials have provided recommendations on biopsy sampling, processing, and analysis for both clinical practice and research. It is important to determine the biologic potential of soft tissue tumors before surgery due to the impact on patient management and prognosis. This often requires histologic confirmation. Percutaneous core needle biopsy of muscle and soft tissue tumors is often performed under ultrasound guidance. It is more cost-effective and less invasive compared with biopsy, and more so, it has lower complications and provides comparable yield rates. However, tissue sampling can be difficult in small, deep, and heterogeneous tumors, and block resection of malignant tumors is mandatory. Therefore, the tract biopsy must be placed within the surgical resection margins. The panel made one recommendation for synovial biopsies with a level of evidence 3, though strong consensus. It says that ultrasound-guided synovial biopsies can be performed safely and might be helpful in the clinical setting for the diagnosis of joint infection when synovial fluid analysis is not available or non-conclusive. The next recommendation for ultrasound-guided core needle biopsies of tumors, this is a long recommendation put all together, and the level of evidence is 2, and we had a strong consensus, and it states, ultrasound-guided core needle biopsies of soft tissue tumors must be done along the planned surgery incision in collaboration with the orthopedic oncologist, obtaining at least 4 specimens of no more than 10 millimeters length each. The target must be the viable tumor regions. Unaffected compartments or neurovascular bundles must not be contaminated by the biopsy tract. Perineural injections aim at depositing local anesthetics with or without additives in the vicinity of a plexus or nerve to achieve analgesia or complete surgical anesthesia. Ultrasound guidance increases efficacy of perineural injections due to more precise injectate deposition, as quantified by more blocks deemed sufficient for surgery following sensory or motor testing and fewer blocks requiring supplementation or conversion to general anesthesia. Also, it improves the safety profile by reducing the incidence of nerve injury and intravascular injections. Ultrasound is effective in reducing local anesthetic systemic toxicity. The optimal position of the needle tip is perineural, and every effort should be made to avoid disrupting the nerve integrity. This panel group made 3 recommendations with good level of evidence and a strong consensus. Real-time ultrasound guidance should be considered for perineural injections. Ultrasound monitoring of the needle tip should be performed throughout the injection in order to avoid intraneural needle tip placement. Ultrasound visualization of tissue expansion, injectate spread without resultant increase of the cross-sectional area of the nerve should be sought. Thank you for your attention, listening and watching this overview in musculoskeletal ultrasound guided procedures. I was over time. I know that. I'm very sorry for that. If anyone has questions, we will be very happy to answer.